Good day, everyone. My name is Oyedokun Hituno Rebecca, a medical laboratory scientist, a public health and research enthusiast. I'll be presenting on a topic called Should CAR T cell therapy for childhood leukemia be fully subsidized by government? I will be on the affirmative side alongside with my team member Suchi Narrate. Speaking of childhood leukemia, acute lymphoblastic leukemia is the commonest childhood cancer and outcome for relapsed refractory B-cell precursor. Acute lymphoblastic leukemia remain a major unmet need despite modern risk-adapted chemotherapy and transplant strategies. This urgent unmet medical need catalyze a paradigm shift from non-specific cytotoxic agents towards precision immunotherapy. Then, a CAR T cell therapy was developed to help combat acute lymphoblastic leukemia. It is a form of adoptive cell transfer. It involves harvesting a patient's T lymphocyte, genetically modifying them outside the body, then after that, synthesizing, expanding them. This is then reinfused back into the patient. In 2017, the US Food and Drug Administration granted the first ever cellular gene therapy approval for patients up to 25 years with either relapsed or refractory B-cell precursor acute lymphoblastic leukemia. Childhood leukemia is not only the most common cancer in children, but also one of the most devastating for families, both emotionally and financially. This is not just another expensive treatment, it is a landmark cure, a living drug that has turned terminal diagnosis into healthy futures. Yet, the cost of a single CAR T cell therapy can exceed hundreds of thousands of dollars, putting it far beyond the reach of most families, especially in low and middle income countries. Therefore, if government truly believe in the right of every child to access a life-saving care regardless of their socio-economic background, then CAR T cell therapy for childhood leukemia must be fully subsidized. My argument is based on three pillars. The very first one is on efficacy and value. According to Mullah et al. 2024, a case study of Emily, a 6-year-old girl who was diagnosed with acute lymphoblastic leukemia, was recorded. She underwent a 2.5 years of standardized chemotherapy. Remission was achieved, but in few weeks' time, a relapse occurred. Leukemia returned. Then, second-line chemotherapy was administered, which failed to induce remission, making a curative transplant impossible. Emily is one of the less than 20% survivor faced with futile effort and costly palliative care by using a standard chemotherapy. As time goes on, CAR T-cell was later introduced, whereby the T cells was harvested from her blood. The cell was genetically modified to target CD19 in her system. This single one-time infusion was done after brief conditioning chemotherapy, and greater than 80% remission was achieved within 28 days. She was discharged from the hospital to continue life as an healthy child. This is a definition of value-based healthcare. Secondly, talking about equity, healthcare must be based on need, not ability to pay. We need to prevent a two-tier system where wealthy means you have a cure, being poor means you have just a palliative care. Take for example, a patient A who came from a wealthy background and patient B who came from a poor background. Both of them are diagnosed with acute lymphoblastic leukemia, and we know that CAR T-cell therapy is the best and only chance for a cure. Then, We know, of course, that since patient A can afford such kind of treatment, he is going to get a cure. Unlike patient B, who comes from a poor background, we only have access to palliative care, and this creates a two-tier system that public health policy must seek to prevent, which is our moral obligation. Third pillar is based on innovation. Innovation, subsidizing CAR-T cell therapy is not just about paying for one drug, it is actively developing the next generation of more effective, safer, and more accessible cures. This is the strategic investment in the future of health. Rebuttal. Firstly, talking about unsustainable cost. However, this is a false dichotomy. The choice is not between funding CAR-T cell therapy and funding everything else. It is between funding a system that cures fatal disease and one that does not. We must not accept that certain children are simply too expensive to cure. African governments can come together and reduce prices in the cost of this therapy, just like the case of retroviral drug for HIV patients. Can we truly put a price on eradicating a child's cancer? Second point, equity across disease. Yes, the burden of malaria, tuberculosis, and malnutrition is immense and requires continued massive investment. Health is not just a zero sum game. We are not arguing to defund malaria programs in order to pay for CAR-T cell therapy. We just want a law of inclusion. A child with cancer deserves a fighting chance, just as a child with malaria does. Looking at it again, we have the infrastructural gap. It is practical and real challenge, but this is not the reason to reject subsidy. No country built a national health system in a day. We can establish one or two centralized world-class CAR-T cell centers in major cities like South Africa, Kenya, Nigeria, where all the complex cell infusion and acute toxicity management happens. Therefore, we must build the bridge while we are crossing it. We cannot wait for perfect infrastructure to exist before we save lives. Looking at the last point, alternative strategies, we absolutely should invest in prevention, early detection, and cheaper treatment. These are essential and complementary, but they are not an alternative strategies because this is the most dangerous fallacy that we must choose. This is not an either or decision. For the child whose leukemia has relapsed twice, prevention and early detection have already failed. CAR-T cell therapy is the only option left. We need a full arsenal, not a partial one. Abandoning children with the most aggressive cancer to fund other programs is a tragic compromise that we must not make. A just society care for its sake, especially the most vulnerable. Closing statement: the right to a cure, a question of principle. This vote is about our value, not just budget. The evidence is clear. CAR-T cell is a transformative cure, but not just another treatment. Let's all rise to reject a two-tier system. Let's have access to life-saving care, which should be a right and not a privilege. Therefore, please, in our choices, let's invest in innovation and compassion. Let's reject inertia and cruel logic of denying chaos based on cost. Final call to action. Let's vote for hope. Let's vote for progress. Let's vote yes to subsidize CAR-T cell therapy and save lives. Thank you.